Thank you very much for that introduction and for inviting me here today. It's a pleasure to be able to speak to you about some of the work that I've done and the field as I see it in terms of the clinical application of some of the differences that Michael described, that the implication of some of these differences of mood disorders between men and women have different treatment considerations that are relevant to women and not men. So I'm going to focus on that in this talk. As you know, women comprise a large proportion of our patient population, and this is accounted for in depression in part because the sex ratio much more higher for women than for men, with up to 2-to-1 lifetime prevalence ratio. This is particularly true during the reproductive years, as here you see women in purple between the ages of about puberty and menopause. Women have twice the risk of depression. It's also true that we see women more because they seek treatment more readily. So I would propose to you that this is highly relevant for all of us, no matter what clinical setting that we are working in. This is the overview of the topics that I'm going to touch on that I think are most relevant for us to be aware of today. Some of the considerations relate to the reproductive effects of the medications that we use on reproductive function, on skeletal health, and then I will discuss some important drug-hormone interactions that are relevant for women's health. And as part of that, particularly for talking about tamoxifen and breast cancer, I will discuss some issues of relevance to uses of psychotropic medication in women with breast cancer and in midlife women. So let us begin by talking about the reproductive and skeletal health effects. I will give you a little bit of background on bipolar disorder and reproductive function. Then I will talk about two reproductive endocrine disorders that our medications are known to cause and contribute to, both polycystic ovarian syndrome, or PCOS, and hyperprolactinemia. And then I will discuss bone health with regard to psychotropic medication. This is a study we did a number of years ago looking at menstrual cycle dysfunction in women with bipolar disorder. It is known that in the population of women at large, approximately 20% or so of women will have menstrual dysfunction as indicated by irregular, unpredictable menstrual cycles, meaning the menstrual pattern is not necessarily monthly. It might be shorter 21-day cycles or many skipped cycles, often many months without a menstrual cycle. And that type of menstrual dysfunction occurs because of certain known conditions in healthy women. And it also occurs, as you see here in our study. In the green, we looked at a unipolar depression population and found similar prevalence rates in the absence of treatment. Whereas in the absence of treatment in bipolar disorder, menstrual cycle dysfunction was much more common, up to about a third. And as I said, that this occurs first in the post-menarchal years, during the teenage years. It precedes the bipolar diagnosis. And of note, you see this similar pattern in epilepsy. So both of these conditions have as part of their presentation sometimes in women menstrual dysfunction. We don't know why that is. But that's relevant for this next topic because when we start to think about psychotropic medications and how they may affect reproductive function, we have to understand that at baseline there is some reproductive abnormalities at an excess rate that we need to assess before we put our patients on some of these medications. So we cannot always assume any menstrual dysfunction is related to the medication, nor can we assume it's related to the bipolar disease or another condition. But taking a careful history, which is a simple thing to do when you're interviewing a patient, will distinguish some of these effects. So the interest in valproate and PCOS came out of the epilepsy literature, where there was a debate for many years in the 80s and 90s about whether this common hormone condition was related to the epilepsy diagnosis or whether it was related to valproate. We, as part of that work, undertook an investigation to look at whether this potential association would be seen in women with non-epileptic conditions of bipolar disorder. And I'll give you a bit of background about this condition. It's a bit like the DSM. You know, you have to have one out of something on this category and something on this category. So it's a bit heterogeneous and somewhat amorphous, but essentially you have to have some evidence of ovarian dysfunction. Most of the time it's this unpredictable, infrequent menstrual cycles. And you also have to have some evidence of androgen excess. Typically, this presents with hirsutism, which is the facial hair on the chin and sideburn. But you can also have male pattern balding or acne. And at times, you might just see a high testosterone on the assay. And these are the women who historically were called the bearded ladies. I think you probably have the same from the circus. These were women who, you know, were in the circus. Nobody walks around like that anymore, and obviously you won't know because these people shave or treat themselves if they have excess hair growth. It's a common condition. It occurs in about 7% of the population at large. Typically starts right after menarche, and although it's thought historically to be part of obesity, there's 50% obese and 50% are non-obese. So that's the condition that I'm going to be talking about in relation to the medication. This is the study we did as part of a large bipolar disorder study called STEP-BD. We took all women and retrospectively assessed we had their chronological medication history, and we also assessed their menstrual cycle function retrospectively in relation to the medication. And then characterized whether they had other features of PCOS, the hirsutism, acne, and so forth. And what we found by comparing valproate to the non-valproate mood stabilizers, which was mostly lithium, was that about 10% of women developed PCOS symptoms after they started valproate. So we excluded everybody who ever had prior symptoms that might suggest PCOS. And whereas, in contrast, you know, there was really no women who developed it after starting one of the other medications. And what some of the other features of this was that when this developed, it always presented within the first year of use. There was never a delay. And we also saw, as has been seen in epilepsy, that the younger the women were when they started the drug, the more likely they were to develop it. But some women started it in their 30s as well. We also followed these women to see we told them that they had this condition and that we thought by history that it looked like it developed after they started this medication. And for those who stopped the medication, we followed them for as long as we could. And we saw that the symptoms were reversible, that their menstrual cycle function came back. It took up to a year, but it came back to normal, which is very reassuring. I want to give you one of the cases of one of the people who was in this study to see how complicated it is to sometimes identify what's happening. So this is somebody who we saw at age 23, but when we took her back, she had menarche at age 12, regular cycles age 21, she has her first manic presentation. She goes on lithium, which commonly causes acne, so nobody would, of course, think anything about that. Her menstrual cycles are regular, and she starts to get hirsutism. Now, hirsutism doesn't start overnight. You know, it takes a long time to develop coarse, dark hair. So after many months, that progresses over time. The hirsutism starts after valproate and risperidone were started, and then she stops having menses while she's on lithium, valproate, and risperidone. And she has amenorrhea for 8 months. So we also know that risperidone is a common drug to increase the hormone prolactin, which causes amenorrhea. So, you know, that would be another complicating factor to diagnose this. But risperidone is stopped, and as I'll show you later, when you stop prolactin elevating medication, menstrual cycles normalize very quickly. But that did not happen in her. She continued to have amenorrhea. and her acne and hirsutism progressed. So she clinically manifested polycystic ovarian syndrome, and here at the bottom was the biochemical profile. Her total testosterone was in the male range, her menopause hormone was in the premenopausal range, and her prolactin was normal. So that's how we would make this diagnosis in these women. And just, out of interest, this woman went off of valproate, and her menstrual cycles, came back within a year, despite the fact that she went on a drug, olanzapine, that caused a lot of weight gain, and despite that, she had normalization of her cycles. This was an epilepsy randomized trial that confirmed the finding that we had in a prospective controlled way, where they took women who had epilepsy and randomized them to lamotrigine or valproate in order to look at the reproductive effects. And they saw very similarly within a year that 7% of women developed new onset polycystic ovarian syndrome features in contrast to the findings on lamotrigine. Also, the earlier they started, the more likely it was to occur. So what causes this? Historically, it was thought that valproate, because of the potential weight effects, would lead to menstrual dysfunction and PCOS because of weight effects. But some very important in vivo studies looking at thecal cells in the ovary found that the exposure of the thecal cell to valproate led to androgen overproduction. So it's a direct ovarian effect that's selected for this drug. No other drug has been associated with that. I told you already that the symptoms emerge within the first year, that they're reversible. And just to describe why this is an important condition to diagnose, there are many reasons. Fertility would certainly be reduced because you have anovulation with the skipped menses. Estrogen levels are preserved, so there's no concern about bone health. But because the estrogen, the endometrium is exposed to estrogen, but there's no luteal phase, luteal function, or corpus luteum secreting progesterone, there's no withdrawal bleed. There's a risk for endometrial overstimulation and hyperplasia. There are cosmetic effects. The psychological effects are very striking as well. When you see, you think about somebody with bipolar and polycystic ovarian syndrome, the psychological effects of not being able to rely on their bodily function or psychological health in so many ways, very profound. The other important reason to diagnose PCOS and be attentive to this is that there's a 6-fold risk of diabetes. So polycystic ovarian syndrome is really related to diabetes mellitus, and the cardiac concerns come through that primarily. Okay, so to skip to what we know about prolactin as an effect of antipsychotics, this is something that has been around for many years, the knowledge that antipsychotics can selectively induce elevated prolactin. You can see here from this figure, this table, that it really depends on which medication you're using. Risperidone and its metabolite are most likely to elevate prolactin above normal, and because prolactin elevation suppresses other female hormones, you don't get ovulation and you don't get menstrual cycles, so you also typically have skipped menses in that condition. The old-fashioned typical antipsychotics also cause this, but usually not as dramatically. Prolactin levels don't go as high, and the menstrual irregularities are not as common, but they do cause it. Fortunately, the other atypicals are primarily prolactin sparing. They rarely raise prolactin, and if they do, it's usually very transient and very mild. So they are primarily considered prolactin sparing. Some interesting work has come out recently with aripiprazole. Do you have aripiprazole here? Yes, that it is not only prolactin sparing, but that it can be prolactin reducing, perhaps because of some of its specific serotonergic effects that's not understood. But in studies in which aripiprazole has been added to an antipsychotic that induces a high prolactin, you can normalize the prolactin with aripiprazole. Now, it's not a primary treatment of prolactin elevation. The endocrinologists would not be using it primarily, but it's of interest, because the typical treatment that you use are dopamine agonists, and the concern, of course, would be that you would destabilize the psychotic features of the condition you're treating, and that's some of the rationale behind potentially adding it. And this is a case also from that study that we did where we identified somebody of having prolactin elevation from risperidone. You can see we saw this person age 43. She was put on carbamazepine at age 42 for bipolar disorder, had regular cycles, started on risperidone and trazodone, and within a few months developed irregular skipped cycles, no hirsutism, and no galactorrhea. That would be sort of a classic presentation of hyperprolactinemia because you can see it's quite rapid. Usually within a few months you see the menstrual cycle changes. The prolactin elevation is quite quick. And when we looked at her blood tests, we also saw this prolactin is well above normal. In women, the normal is 20 nanograms per milliliter. So that was confirming the diagnosis. So the mechanism of action for this is quite well understood that antipsychotics block dopaminergic control of prolactin release. So the antipsychotics interfere with that tonic blockade. Unlike pituitary tumors, which would cause an anatomic effect, a microadenoma, this is a physiologic phenomenon. So if there's an MRI of the brain, you would not see any anatomic effect. It's a physiologic effect. And although it's not really well understood why some antipsychotics would cause this but not others, some of the ideas that have been proposed and tested is that it may relate to the degree of antagonism, the duration of receptor antagonism, reduced blood-brain penetrance because this is at the level of the pituitary outside of the blood-brain barrier, and perhaps the serotonergic affinity plays a role as well. I mentioned that the effect is rapid and it's reversible. Once the medication dose is reduced, often you can see normalization of both the prolactin level and menstrual function, and certainly with stopping the medication. In terms of the clinical consequences of high prolactin, fertility is, of course, one concern in the population in general. In a population not seeking fertility, what would be of primary concern is that you do get very low estrogen levels. And over time, with anovulation and low estrogen levels, these women are at risk for osteoporosis. And actually in men, although this talk is really primarily focused on women's health, in men this is the same problem, and it's a big issue because you don't have a menstrual marker that alerts you to the fact that the prolactin is elevated, and of course in a man where the testosterone levels would be low, and over time chronic low testosterone would put a man at risk for osteoporosis as well. So it's very much a problem there too. So sticking with bone health and thinking about some of what we know about the drugs that we use very widely that can cause bone effects. There's been some epidemiologic studies looking at use of SSRIs and their effects on bone health. And all of these studies were done primarily in older postmenopausal women who are at risk for osteoporosis on the basis of having low estrogen. And these studies found that the longer the SSRI was used, the greater the likelihood of reduced bone mass over time, bone loss, greater bone loss, and risk of fractures. These studies compared SSRI use to non-users and also to women using tricyclic antidepressants. However, what's interesting is that we don't really know the diagnoses of these studies as to why people were taking these medications. The thinking is that the tricyclics, which mechanistically this is thought to be a serotonergic effect, and of course most tricyclics are serotonin-based as well. But the tricyclics were often used at low doses, and so probably used for sleep or pain or headache or something, and that may be playing a role. There's a lot more work to do about this. The big concern is this issue of confounding by indication, so that if the SSRIs are being used for depression and the tricyclics are being used for other non-mental illness conditions, depression in and of itself is known to have adverse effects on bone health, probably because of lifestyle changes, lack of activity, smoking, other health behaviors that don't promote good health. So it's not clear yet whether this is a drug effect or a depression effect. There's some interesting work that we're following up on which tries to understand the mechanism that this may have to do with a serotonergic effect in the gut, and you do see that would lead to the serotonergic activity through the absorption of the medication and these serotonin receptors on these bone cells. So a lot of work which is being done looking at this. When you look at antiepileptics, most of the work here comes from the seizure population, medications that we don't necessarily use. But again, you will see that the effect has been notable in postmenopausal women, whereas in premenopausal women, you don't tend to see this effect, in part because the estrogen protection is so profound for bone health that it would be thought to override any potential adverse effect of the medication. But you do see in postmenopausal women, with medications, some of which we use, carbamazepine, clonazepam, gabapentin, but not valproate, adverse effects on bone health. Still questions about whether this is related to the drug or to the epilepsy condition, because again, epilepsy is associated with lifestyle behaviors that might not be as good for bone health promotion. And with regard to antipsychotics, I've already said that because the prolactin elevation therefore leads to suppression of ovulation, therefore leads to lack of estrogen to protect the bone, you can have, with prolonged treatment, you would not see this with a few months of amenorrhea, but with prolonged treatment there is a risk for osteoporosis. So to summarize that section about what we know about skeletal health, these are earlier studies and we don't have definitive causative information yet. It's hard to distinguish drug from disease state. Does appear that there's a dose, duration of use effect, and whether that reflects a more severe depression or prolonged exposure of the bones to these medications is still not known. In terms of clinical implications, nobody would say that you would withhold an SSRI from a postmenopausal depressed woman because of this. Certainly the field is not at that stage. You certainly would be wanting to promote bone health in general in anybody who you would worry about both estrogen deficiency, testosterone deficiency. And so you want weight-bearing exercise, calcium, vitamin D, and at times you might think about medication substitution, but that would be very case-specific. Okay, I think I've convinced you, I hope, that we have to be aware as we use these medications, which are so helpful for our patients, that we have to be aware of certain conditions that we can cause or potentially complicate by using them, and these include polycystic ovarian syndrome, hyperprolactinemia, and the more preliminary evidence about bone health. I'm going to conclude that part of the talk and move on to the second part of the talk, which deals more with drug interactions and midlife women. So when it comes to drug interactions, I think the estrogen interactions are relatively well known, I hope. The issue here, there are two types of interactions. The most common primary concerns are the ones on the left here, which is that because exogenous estrogen administered in a birth control hormonal preparation would be metabolized in the liver through a 3A4 enzyme, by using a 3A4 inducer, you can reduce the level of estrogen in the birth control preparation, therefore making it too low to suppress ovulation, which is how estrogen birth control preparations work, and therefore you get in an unexpected pregnancy. And this was classically described with carbamazepine, which is the most famous of all. 3A4 inducers, we have seen a lot of carbamazepine babies in this situation because somebody was put on carbamazepine and her birth control preparation was made to be ineffective. But the same is true for the other medications that are 3A4 inducers, the metabolite of carbamazepine, oxcarbazepine, topiramate, and modafinil. So each of these 4 drugs, whenever there's a birth control preparation that relies on suppression of ovulation and absorption and first-pass metabolism through the liver, this is an issue. So it comes an issue with, of course, any oral preparation because you have hepatic metabolism, first-pass effects, also with the vaginal birth control preparation, which is available in America. The patch or the transdermal birth control preparation, because it doesn't have first-pass effects, this is not an issue. So that's a nice alternative for birth control. The other being, of course, barrier methods. It used to be before the patch came out that we put women who had to be on carbamazepine, on very high doses of birth control pills, and we had them use barrier methods. And you sort of crossed your fingers and took a chance. So it's nice to have alternative options. The other side of the slide is about a different kind of interaction. It's not one that affects the efficacy of any estrogen preparation. It's really the flip side, which is that estrogens, whether they're endogenous or exogenous, can alter lamotrigine levels, thereby theoretically reducing the efficacy of the medication. And so you see this because the clearance of lamotrigine is increased by estrogen. So it doesn't stay in the system, it gets metabolized much faster. And it comes up as an issue a lot in pregnancy when you have very high estrogen levels. In our hospital at Mass General, where we use lamotrigine very widely in pregnancy, both for epilepsy and for bipolar disorder, the epileptologists are very careful, and they tend to try and manage lamotrigine in pregnancy according to blood level, and they measure it every trimester, and they are very conservative about dosing it according to the pre-pregnancy blood level. We have not done that so much in bipolar, where we have not, lamotrigine is not dosed as clearly according to blood level, and we haven't found as much of concern about breakthrough of symptoms, so we treat people clinically. It also comes as an issue if you are starting lamotrigine in somebody on a birth control preparation that includes an estrogen component, that you might need to push the dose higher than you would in somebody who's not. So you might expect that the blood level is reduced by virtue of the co-therapy with the estrogen. So it's sometimes an issue in that case. And I think it varies a lot, how much this matters. Some people are very brittle in their management, and they are very susceptible to small changes, and they can't tolerate it. And some people have no problem with this interaction. And remember that the reduction of lamotrigine levels varies, so it's up to half. So some people have very little effect, so this is not a universal phenomenon. Okay, I work a lot with breast cancer patients, and this issue of how to manage drug interactions with tamoxifen has been a big concern recently. And so we're getting back to pharmacology and hepatic interactions. I'm going to talk about 2D6 interaction, and as part of this I'm going to talk about how we think about psychotropic drug use in breast cancer patients and the population who has this, primarily the midlife population, talking about hot flashes and depression. I like to anchor this with a clinical context so you see how this applies. So this is a type of patient I would see. She's 48. She has horrible hot flashes, sleep maintenance insomnia. She has terrible mood changes, and she has perimenopausal skipping of her periods for 15 months. She has a psychiatric history notable only for anxiety and depression 10 years previously. When you get into more details about her presentation, you find out that her hot flashes progressed over 9 months, so consistent with progression through the perimenopause. But then she was diagnosed with ductal carcinoma in situ breast cancer, and for which some women will receive tamoxifen. And in the context of the tamoxifen being added, she had much worse hot flashes. She was bothered during the day, but mostly at night because she was waking up. And she was the kind of person who they go to bed with a pile of pajamas next to their bed, and their bed partner has a hat and gloves, and 2 blankets. And in Boston in winter, she's very, very hot. So it was a big problem for her. The depression was classic depression. She was very hopeless, lack of interest, energy, concentration, very guilty, and she was not functioning very well. She had stopped working. And the sleep disturbance was classic for hot flash related sleep disturbance, waking up repeatedly, and as she would wake up and ruminate and worry, she would not fall back asleep. So she had quite fragmented sleep. So to think about the use of these medications in breast cancer, the population that has breast cancer is primarily midlife women and older. Depression is very common in this population. The clinically significant depressive symptoms occur in somewhere between about a quarter of women. And so these co-therapy with SSRIs in breast cancer patients who are often on tamoxifen is very common. The other reason that SSRIs and SNRIs would be used is because of treating hot flashes, which we talked about with this case, in part because the population very commonly has hot flashes, in part because they may have had their ovaries removed to treat their breast cancer if they're premenopausal, and then because the medications, the anti-estrogen medications that they use, widely cause hot flashes with tamoxifen, and up to 2/3 will get hot flashes. So administering an SSRI, which as I will show you are effective non-hormonal alternatives to treat hot flashes, is a very common co-therapy with tamoxifen treatment. And so, you say, well, why treat the hot flashes? Because they don't have to be treated. There are clear quality of life benefits for those who have a lot of daytime discomfort. There are sleep effects which can be treated as you reduce the hot flashes, and of course fatigue and depression. So there's some clear argument from a quality of life standpoint for why you would treat the hot flashes. But in the breast cancer population, this is a big issue with adherence. So hot flashes are the primary reason that women stop tamoxifen. So if you can manage this most common side effect, you can help with adherence to the treatment. So 1/3 of women will discontinue tamoxifen in relation to these symptoms. So why is this relevant? Well, tamoxifen is a prodrug. It has to be metabolized in the liver to have its breast cancer efficacy. And in order to be metabolized, it has to be processed primarily, you see here, through 2D6. And there's, our drugs, and this is what I'm going to focus on, can affect and inhibit 2D6. And as a result, you can reduce the metabolites levels that have the efficacy. So that's the concern, is that we're blocking the metabolism of this drug to limiting its efficacy. There was a big study done looking at this concern, and it was in 24,000 women taking tamoxifen for breast cancer. 1/3 of them, 30% here, were on SSRIs or SNRIs. And this was 2010. At the time, the medications that were used you can see paroxetine was the most commonly used SSRI or SNRI, as well as sertraline and citalopram. And what they did was they looked to see the number of deaths over time in this group of women, and looked at whether use of any of these medications, which have differential effects on 2D6 inhibition, were associated. And what they found was that breast cancer mortality was associated with paroxetine use. Now, paroxetine is clearly a potent 2D6 inhibitor. And so the thinking has been that it's because of this inhibition effect that the tamoxifen may have been less effective. This association was not seen with the other agents. And of course, you will know that fluoxetine is also a very potent 2D6 inhibitor, but it's possible that that was not detected because the sample size was much smaller. Some of the other agents, venlafaxine is negligible effect on 2D6, so it's usually the preferred medication. And sertraline and citalopram also have moderate effect. So the 2D6 inhibition of the medications that we're using in somebody with tamoxifen should determine their use where possible. And we try as much as possible to use those that are minimally inhibitory in order to avoid this interaction. And this website from a colleague in Indiana is a nice list of the drug-drug interactions. I will say, as we used duloxetine is a very potent 2D6 inhibitor, bupropion, a very potent 2D6 inhibitor. So those medications that you might not think of as much, we need to be careful when somebody's on tamoxifen. It's a good time to look it up, because I can't remember it. It's very hard to remember the list. So the interactions that are important are the estrogen interactions because of the contraceptive efficacy being diminished, the potential for destabilization as lamotrigine levels are reduced, and also the tamoxifen interactions because of potentially reducing tamoxifen efficacy. Why we would be using these drugs in this population is the next section of the talk, and I'm going to talk first about what we know about perimenopause and depression, and then about hot flashes. Historically, there was a big debate about whether depression was part of menopause, and there's good data now showing that depressive symptoms, subsyndromal mild symptoms, are very common in the perimenopause and early postmenopause, and that there's an increased risk, including increased risk of first lifetime experience of mild depression symptoms. There's also an increased risk of clinical depression in the perimenopause and early postmenopause, and most of this is recurrence of depression, but this particular hormonal situation is thought to underlie why it might be a period of risk, like you would see with postpartum depression. The data on whether it's a period of risk for first lifetime episode of depression are much more mixed. So diagnosing depression in this population, there's nothing special about it. It's a clinical diagnosis of depression in the context of somebody who meets clinical perimenopause criteria, which are clinically based, irregular, infrequent, or unpredictable cycles, and often you see hot flashes. And so you will see that depression commonly co-occurs with hot flashes and sleep disturbance. There's no blood test that would say, aha, this is depression related to menopause. So there's no point in determining a blood test for the purpose of depression assessment. But you will know that the perimenopause, the hormone fluctuation with estradiol, you see very erratic, wide fluctuations of estradiol leading up to the final menstrual period. And when you think about depressive symptoms, this population often has a lot of PMS, premenstrual irritability. Some of them will say that they feel like they are premenstrual all the time. Those who had PMS previously will feel that that doesn't stop and start, it just continues all the time. So that can be a part of the more of an irritable presentation. Causes of menopause-associated depression, there's a very long list from the epidemiologic literature primarily. I'm going to focus on these three types of causes in red, that there's been some strong associations with sleep disturbance related to hot flashes, also with some of the changing hormone profiles, and then of course recurrence of depression, prior anxiety, prior PMS. But there are other factors as well, including strong factors of stress and stressful life events. This was a study we did trying to understand the contribution of sleep to menopausal depression, and we used an intervention study to get at this. We took healthy women with depression, hot flashes, and sleep disturbance, and we randomized them to 3 interventions: estrogen, zolpidem to isolate their effect on control their sleep, and placebo, and then assess their depression outcome. And in this intervention study, which was a relatively small clinical trial, we didn't see any differences in terms of the drug effects, so all 3 groups had improvement of mood over the 8-week period. But we also saw highly variable degrees of sleep response to these treatments. And we saw that as the sleep improved, as measured on questionnaire, the Pittsburgh Sleep Quality Index, so the mood improved as measured on the Montgomery-Åsberg Depression Rating Scale. So that was a sort of an indirect way of trying to understand that as you improve sleep, so you improve depression. We have now been following this up using more objective measures of sleep, using polysomnography to understand the contribution of sleep to depression, because it relates in this population to the effects of hot flashes on sleep as a primary predictor for why mood may be disturbed. It may be that the hormonal instability leading to the hot flashes in a very sequential way, to the extent that the sleep is disturbed, might contribute to hot flashes. And it's really a lesson for prioritizing treatment of sleep when you manage depression in general, but particularly in this population. In terms of the hormone dynamics, this was an interesting study getting at how changing hormones in and of themselves might contribute to depression in the perimenopause, which helps us to understand that the brain responds to very erratic, variable estradiol levels. The more variable as somebody progresses through the menopause transition, the greater the likelihood that she will develop a depression. So there is a hormonal basis to this condition. And in terms of recurrence, I know, in a depression psychiatry community, we of course think of depression recurrence as being the cause of why depression occurs, but in a gynecologic community that may not always be the first thought. There may be more of a distant history of depression, but depression, as we all know, recurs, and women are more likely to have recurrence, and this is a very elegant study showing that over time the risk hazard of depression increases in women more than in men. Now, treating depression in menopause is a very straightforward thing to do, in that we have important antidepressant options. These studies we undertook years ago with antidepressants at a time that it was thought that menopause, if it was the cause of the depression, then it shouldn't necessarily respond to a traditional antidepressant, that you might need the hormone treatment. So nowadays that seems counterintuitive, but antidepressants work even if this is hormonally driven. You have the advantage of using serotonergic drugs that would also treat hot flashes, like I will show you shortly. So you can kill 2 birds with 1 stone in using those drugs. Estradiol also works to treat depression in this population. There have been a few small studies showing the efficacy of estradiol relative to placebo for perimenopause and early postmenopausal depression. It's thought to be that, it may be that you're treating hot flashes and therefore improving sleep and therefore improving mood, but it's hard to know. Of interest in an older postmenopausal population without hot flashes, primary therapy with estradiol was not helpful. There may be something specific about the hormonal milieu of the perimenopause or the symptomatic population that presents with hot flashes and depression. Nowadays, we typically don't use estrogen, off indication. Our use will be much more restricted to its primary treatment for hot flashes, but this is important history. Okay, so hot flashes, to conclude this talk. The hot flashes are the primary symptom of the menopause. They are a physiologic phenomenon in which there's a brief transient sensation of warmth and flushing in the bust and the upper body. They are a heat dissipation event, and the biology is not very well understood, but there's thought to be a reduced thermoregulatory zone so that somebody would tolerate heat changes, core body temperature changes in a certain range of temperature, and that range is reduced in somebody who has hot flashes. But there's still a lot of work to be done. For somebody who's never heard of what a hot flash could be like or doesn't know anybody who's complained of it, I say that it's like embarrassment. It's much worse than embarrassment, but it's that feeling of a rush that comes out of the blue and then dissipates. And that's sort of at the mildest form what a hot flash would be. I mentioned that these are very common in menopause and also with breast cancer treatments as well as osteoporosis treatments. Something like Prolactin, which is an anti-estrogen in the brain, will also cause hot flashes. Risk factors are of interest because there's a lot of psychological factors that those who have more heightened bodily awareness, symptom sensitivity, are more predisposed, as well as a history of depression, anxiety. And smoking, smoking and elevated body mass index are core risk factors. So this is the sort of model now of what causes hot flashes, that is clearly a central nervous system component, and that is because the thermoregulatory region is in the hypothalamus, in the preoptic region, primarily in the hypothalamus. So that's thought to be the region through which hot flashes may be mediated. A very young field, and some early work we and others have done have tried to localize hot flashes in the brain. The two regions that have been of interest are the insular cortex, which after the amygdala should be of interest to mental health because it's a large cortical region that is involved in pain sensation, emotional processing of bodily sensations. A lot of anxiety research has shown differences in insular cortex activation. So it's an important region for a bodily sensation like hot flashes. And of course the hypothalamus, because of the thermoregulatory zone, and also because you get estrogen feedback to the medial basal hypothalamus. So one of my colleagues did an interesting functional imaging study of hot flashes in which he induced hot flashes in the MRI. And so I don't know if anybody has had an MRI before, but you can imagine people have to lay there and they wrap them in blankets and warm them and wait sometimes up to 2 hours until they have a hot flash, and the hot flash is measured using a skin conductance monitor, so it's physiologically monitored as well as perceived. And they did this in, these neuroimaging studies are always small, 12 women who had hot flashes, VMS, vasomotor symptoms or hot flashes, and their control group was women who didn't have hot flashes, and what they induced in that population was sweating. So this comparison is sweating versus hot flashes. And they were the first to identify the insular cortex as a region of interest for hot flashes. So during the hot flash, this region of the brain was activated relative to those who didn't flash but sweat. So that really put the insular cortex on the map for this field. The other area that they wanted to look at was the hypothalamus, but because of the small size of the hypothalamic structure, they would not be able to address that. We then took a different approach to study this, in which we looked at biomarkers of hot flashes. So what we did was we took, in this study here, you see women who went on leuprolide, which is a GnRH agonist that induces a medical menopause. We do these studies in healthy volunteers. We put them into menopause within 2 weeks, just temporarily. And then we took breast cancer patients who went on for their treatment, tamoxifen, aromatase inhibitors, and these GnRH agonists. And we looked to see whether they did or didn't develop hot flashes. And you have this nice opportunity because some people do develop them, and in the same estrogen deprivation model, some people don't develop them. And so you can compare these two groups. Now, we knew they didn't have hot flashes before. And what we did is we did a PET scan because we were looking at resting state metabolic activity before they ever saw an estrogen deprivation challenge. And we, because PET doesn't have the same anatomic precision, we use structural MRI co-registration to define the hypothalamic structures in particular. So the analysis I'm going to present to you is for this pre-treatment biomarker that we found in the insular cortex, that the women who developed hot flashes here in the pink had lower baseline resting state metabolic activity as an indicator of a neural biosusceptibility to hot flashes. So you can almost predict, using this, of course, very expensive methodology that you would never use clinically, but you can tell that there's a biological predisposition. So when people tell you, that they feel like hot flashes are in their head, like they're just making it up, I always say, yes, it's in their brain. This is very much a neural process. We were able to look at the hypothalamus because of the detailed approach that we used, and we similarly saw reduced activity in the hypothalamus in the thermoregulatory regions and in the estrogen feedback regions to the GnRH neurons. So this is preliminary work, which if the NIH will give us funding, we hope to do much more of for breast cancer patients. Okay, so I've convinced you that hot flashes are important. So what about treating them when you don't have estrogen as an option? This is a summary of the randomized controlled trials that have studied our medications against placebo. And a plus here would mean that there was a trial that showed drug was more effective than placebo, and a minus would show that drug was no more effective than placebo. So you can see overall that most of the studies have shown additional benefit of the medication, both SSRIs and SNRIs, relative to placebo. And these are all used off-label, used very widely, of course, in breast cancer patients or anybody who can't take estrogen, and anybody who would want to avoid estrogen as well. I'll highlight one of the studies that we've done, which was with escitalopram. This is through a large NIH consortium that we're part of, and we showed over an 8-week period that escitalopram reduced hot flash frequency more than placebo. Every hot flash study will look like this in that you never get to zero. You don't cure hot flashes. You don't obliterate them. I tell my patients that we take mountain ranges and we make little molehills. You reduce frequency, you reduce intensity, you reduce bother and distress. And that, for many people, translates into substantial improvement. You also see in every trial that there's a strong placebo effect, which is no surprise to those of us who do depression studies. And the other thing you see is that within the first week, you always see partial benefit. So you're not treating depression. In fact, we excluded depression. Most of the studies, depression, anxiety disorders have been excluded. So you're not treating depression. You are directly having an effect on this condition. The other thing you see is that you don't get additional benefit usually after 4 weeks. So if you're using it, you get rapid benefit, and you don't need a long trial. Venlafaxine is used most widely in breast cancer patients because you don't have to worry about tamoxifen interactions. I think a lot of the oncologists are very familiar with it. These were the pivotal studies done by some medical oncologists showing that doses in the red here of 75 and 150 were both more effective than placebo, whereas 37.5 did not statistically separate. Same pattern, early benefit sustained through 4 weeks. And this was a very large study with desvenlafaxine. Looking here, if you look in the red squares, the lower dose of 100 separated from placebo, again, within the first few weeks. So if you use one of these medications for hot flashes or you're using it for depression, you can expect this kind of benefit. Overall, you could see that low doses are effective, that you get partial benefit, that you get a significant effect rapidly, and there's no mood effect to explain it. Very briefly, to think about non-serotonergic treatments, bupropion would be a great model to study. Very little known, except that one very small study showed no benefit for treating hot flashes. And interesting work, particularly with gabapentin, which we in psychiatry use off-label, of course, but it's being shown to be very effective to treat hot flashes. Here are the two trials for it. One study showing benefit here in the blue at 900 milligrams divided 3 times a day, whereas 300 was no more effective than placebo. Another study at 2400, a higher dose divided 3 times a day, showed benefit relative to placebo and in a similar range to the effect from standard dose estrogen. So gabapentin, which does not have any tamoxifen interaction, is also an important option for these breast cancer patients. This is a study that we're just finishing now, so I don't have results, but hopefully we'll in a few weeks. 339 women with hot flashes randomized to low-dose oral estradiol, venlafaxine at low dose 75 or placebo for 8 weeks. The idea here is that we know that these medications are helpful, but the impression is they're not as good as estrogen, but there's never really been these head-to-head studies, nor has there been studies with low-dose estrogen, which is not as effective as standard dose. So we hope to be able to inform people soon about the benefit. So going back to the patient that we talked about who was multiply symptomatic, referred from an oncologist, this is how her course went, in that she has been put on venlafaxine to treat her hot flashes. She had some benefit, but she was still had night sweats, and those were most bothersome to her. And she could also see that her mood was improving as she was approaching 100, and usually, of course, we use 150 for mood benefit. So the next step would be that we would increase it to 150 at least to see that she would get both mood benefit and hot flash benefit. Here are just some of the considerations that you can see if the sleep problems respond as the depression gets better and the hot flashes resolve. And of course, we end up sometimes adding hypnotic therapies to treat sleep more generally, or gabapentin to treat hot flash-related sleep problems, or mirtazapine, which is not a 2D6 inhibitor. So all of those would be important adjuvant therapies where you would want to avoid 2D6 inhibitors, as I mentioned earlier. So I've convinced you, I hope, that these are relevant issues because we see a lot of women, because our medications can have important health risks on reproductive function and skeletal health, and similarly because our medications have important drug interactions, as well as potential benefits for women's health. These are all the people involved in all the research that I do locally, all in Boston at Mass General, in psychiatry and neuroimaging, in endocrinology, Dana-Farber and Mass General oncology, and sleep medicine at Brigham and Women. And thank you to all the people who provide funding for this research at the NIH and some of the Breast Cancer Foundation. Thank you for your attention.